my esteemed senior colleagues, young friends, ladies and gentlemen, I deem it a great honor and privilege to participate in this international conference on current updates in psoriasis. I thank Professor Manohar and his team for inviting me to be the chief guest and also deliver the inaugural address. As an octogenarian, I'm a virtual Rip Van Winkle, so I'm not competent to talk about recent advances in immunology, genetics, biologicals, and so on. I leave it to the younger generation. I will just briefly trace the evolution of this fascinating, enigmatic, worldwide disease, which has today become one of the most researched topics in dermatology. You may wonder, why talk of the past when your discussion is mainly biologicals and beyond, which means the future? So William Osler, the great physician, once said, "It is only by the historical perspective that many of the integral problems of medicine can be profitably solved." So we'll briefly consider the history of psoriasis down the ages. There are descriptions of skin diseases in ancient writings, which we can say is psoriasis, like in the Ebers Papyrus, 1600 BC, the Indian Vedas, 1500 BC, Chinese manuscripts dating back to 3000 BC, the Old Testament in the Bible, 1500 BC, the Hippocratic collections of 300 BC, and also in the writings of Census, 225 BC. We skip over the next few centuries, which is known as the Dark Ages of medicine. We come to the post-Renaissance period, 18th century AD. Credit should be given to Robert Willen, who was also known as the father of British dermatology, for giving the first accurate description of psoriasis as we know it today. He did this along with his student Samuel Plum. So we sometimes call psoriasis eponymously as Willen-Plum disease. In my postgraduate days at St. John's Hospital for Diseases of the Skin in London, this was in early 1960s, we were taught by the senior consultants. So there are only two pathogenetic factors. It was called the dual hypothesis proposed by Radcliffe Cockcroft. One is the increased mitotic rate of the epidermis, and two, the dilated tortuous blood vessels in the dermal papillae, which periodically squeeze out polymorphs into the epidermis to form the Monroe's microabscess. That's it. These are the two pathogenetic factors. No importance was given to the lymphocytes which were hanging around in the dermal infiltrate. Indeed, at that point in time, our knowledge of lymphocytes, I'm talking about the 50s, our knowledge of the function of lymphocytes was very limited. In the book I followed in the 1950s as a medical student, a textbook of pathology by William Boyd, which I'm sure my good friend and classmate Dr. Veerabhav will also remember. There, Boyd mentions about lymphocytes. He says, they are there, they meaning the lymphocytes. They are there at the periphery of all inflammatory cell collection, like phlegmatic observers, passively watching the turbulent activities of the polymorphs. The polymorphs were always there, jumping about here and there. Lymphocytes were sitting there quietly. But today we realize that it is these lymphocytes which are the driving force in the pathogenesis of psoriasis. Most of the biologicals that are in use, which will be discussed a little later, they target either the lymphocytes or their cytokines. In spite of accumulating so much knowledge and information about psoriasis, we are still awfully ignorant about the etiology, the cause of psoriasis. We call it polygenic, multifactorial, idiopathic, and so on, hide our ignorance. In fact, there was a cardiologist, late Dr. K.P. Misra of Apollo Hospital. He used to teach his students about idiopathic cardiomyopathy. He told them, friends, we call it idiopathic because the treating physician looks like an idiot and the patient looks pathetic. We call it idiopathic. I think the same holds good for psoriasis also. Still idiopathic. All dermatologists will be familiar with psoriatic patients, their own, were well under control and remission, suddenly getting worse when exposed to stress. It is unlikely that the psoriasis will come under control unless the stress is removed. It's true for many skin diseases, but particularly for psoriasis. And today we know the scientific explanation for this clinical observation, which is that the stress putatively acts via the psychoneuroendocrine immunocutaneous pathway, with various neuropeptides liberated at different parts, acting as common words in a dynamic dialogue which is going on between these various systems. Psoriasis is normally considered to be only a cosmetic problem. Indeed, in the last century, the Italians called it morbus fortiorum, which means disease of the strong. So they felt, but for the skin lesion, these patients were healthy. But today we know that's not correct because we consider psoriasis to be part of the metabolic syndrome. But even in patients who have no metabolic syndrome, who have only psoriasis, it can sometimes be very incapacitating. This used to be a favorite question of my late chief, Professor Thambaya. He used to ask, what are the clinical scenarios where patients with psoriasis get disabled? Number one is when it goes on to assume this pustular form, the generalized pustular form of Zumbush, which can even terminate fatally. Secondly, when it becomes exfoliated, the whole universally involved. Thirdly, when there is a severe mutilating arthropathy. And fourth, in the so-called palmoplantar psoriasis, the hyperkeratotic type, there are deep fissures. It makes walking difficult for these patients. They can't use their hands also. They become terribly disabled. And lastly, iatrogenic. The numerous drugs that are given by us and the alternative medicine people invariably at some point gives them problems with the liver, spleen, or the kidneys, and so on, and lands them in a hospital, disabling them. This is why father of medicine, Hippocrates, said, primum non nocere. Firstly, do no harm. A humiliating fact in our day-to-day practice is that we still do not have a diagnostic test to confirm a diagnosis of psoriasis. You take syphilis, you've got the media. You take typhoid, you've got VIDA. You take the autoimmune diseases, you've got the AMD. Not so for psoriasis. Even today, the diagnosis is mostly clinical. Another depressing experience we sometimes encounter is there are times when, in spite of our wielding all the different weapons in our therapeutic armamentarium, including the biologicals, telling the patient, oh, you'll be all right, I'm giving you the biologicals. In spite of this, the condition keeps getting worse. This is what is called paradoxical psoriasis, about which Dr. Dr.Yesudian will be talking this afternoon. And this is why a wag once said, psoriasis is an antidote to a dermatologist's ego. What is the future beyond biologicals? The gaps in our knowledge regarding psoriasis should be addressed by the future generation of dermatologists. Just list a few of these. Firstly, we need robust statistics about the prevalence of psoriasis in our country. How many out of the 1.3 billion Indians suffer from psoriasis? Most of the statistics we quote are from other countries. We don't have our own statistics. So we have to open a national register of psoriasis so that we know the magnitude of the problem of psoriasis. It's possible. I mean, we did it for leprosy. Why not do it for psoriasis? Secondly, we must try to identify the putative autoantigen in the epidermis against which the T lymphocytes are active. Thirdly, we should try and find a good animal model to experiment with. The leprologists had the 9-banded armadillo. Like we can try and get an animal model when it will be easier for us to do experiments, find the cause, and also to try newer drugs, and thus not using human beings as guinea pigs. And finally, newer therapeutic approaches would require a close cooperation between the dermatologists on the one hand and the pharma industries and the biophysicists on the other. So these are just a few suggestions I would like to convey to the younger generation of research-oriented dermatologists. get an answer to the question posed in today's conference. What do we do beyond the biologicals? I'm sure that the PG students attending the conference will benefit greatly by the many new facts that will be brought out in the conference. And I congratulate Professor Manohar and his team for organizing this meeting. And I thank Dr. Manohar especially for giving me this moment in the sun. Thank you.